So my objectives today are to keep you awake, first of all. So I've got some activities planned to discuss at your tables. You don't have to speak up if you don't want to, but try to entertain you at least. So we're going to describe metrics for antimicrobial stewardship, inpatient and outpatient long-term care. And then the idea really is to help you design a plan for taking back some of the information that you've had discussed today, some ideas, and put it into action to form an action plan to improve the quality of your patient care. So that's what the activities are going to be about. You know, what are the problems with metrics? So look at this slide and the number of vancomycin concentrations taken per course of therapy. So think about or discuss what's good about this and what's bad about this. So we've got some month-to-month counts of how many levels per course of therapy. The good part is these are usually pretty easy to obtain. Like, you can run a report. That's half the battle, is finding something that you can measure and get a report of and track from month to month. The problem with this is it's really not standardized. The course of therapy could be 30 days if you have a patient with a bone and joint infection or endocarditis, and then you could have a patient on it for 3 days. And then finally, the levels themselves don't tell you about the quality of the care. Did people get cured? Were they within range? So just because you have a number or something to monitor doesn't mean it's the best metric or something that you should put a lot of time and energy into. Now, the goals of every stewardship program are fourfold, sometimes more, but these are the main things: to improve patient outcomes, to enhance patient safety, reduce antimicrobial resistance, and also lower your antibiotic costs at the same time to help pay for the program. An ideal quality measure doesn't exactly exist for stewardship, but these are the traits that we want to look for. So first, that being easy to assess compliance with, being able to monitor, something that will improve practice and change behavior so that it's not just all a retrospective evaluation. And then one that has no unintended consequences, where you may be improving one aspect but worsening care in another. And then it'd be ideal too, if you work across a health system, that you could use this metric inpatient, acute care, or long-term care in adults and pediatrics. And then one that's useful to many audiences, not just the stewardship staff, but clinicians on the front lines. You could use it for accreditation and also share it with administrators as well. Now, there are so many different metrics. I've broken them up into 3 different categories to help you process this. For process measures, these are things that we're doing with the antibiotics. So consumption, like how much are you using on a monthly basis? And then appropriateness, is this the right choice for each infection? And that's what we've been trying to talk about today to help you make informed decisions. It could be the time to appropriate therapy, or also just documenting indication. That's one of the best practices that CDC is pushing for, Joint Commission is pushing for, is simply having the indication on each antibiotic makes your job a lot easier in stewardship to understand why it's being prescribed, and then you're able to assess appropriateness a lot easier. 5 years ago, that was really not the standard, so we have come a long way in that, in making indication more the norm than the exception. For outcome measures, these are things that happen because of the infection, because of antibiotic use. So, of course, infection-related mortality would be nice if we could track that. I know it's difficult to monitor and more difficult to influence. But in any small study that you're going to do, at least you want to track that to ensure and reassure people that it's not getting any worse. Those studies with respiratory tract infections and shorter courses or discontinuing antibiotics, they didn't lead to any worse outcomes, but we were able to do it with less antibiotics. Length of stay and readmission rates, those are really hot topics right now, trying to keep the admissions down and make sure people don't come back with unscheduled visits. Clostridium difficile rates are probably the easiest to track here. There is a lot of regulatory pressure on that. Ways to track that. It's fairly easy to get a report. Resistance rates, something else that most of us track from year to year with antibiogram. And then with any intervention, you want to monitor the clinical success rate and cure rate. The third category is structure measures. So how is your program set up? And this is really the core elements that Dr. Srinivasan was talking about. Have you met all 7 core elements? Do you have the pieces in place? And even within those, there's areas where you can expand to improve on how well you're meeting them or how robustly your program operates within that broad framework. Starting with measures of antimicrobial use, there's 2 main process measures here. Defined daily dose is an older version that's been adopted and implemented by the World Health Organization. This gives each antibiotic a standard dose, and it could be ceftriaxone, for example, is 2 grams. Levofloxacin is 500 milligrams. They may not always be the doses you're using, but it's an average dose. And this was really used more when systems could aggregate your monthly antibiotic use, and then you could simply divide it by, if you had used 10,000 grams, you can divide it by 30 or 31 to find out how many grams per day you used and find out how many defined daily doses that was. As electronic medical records have become more sophisticated, it's become easier to measure days of therapy, and this is now becoming the preferred method that we will use in stewardship going forward. This is what Dr. Srinivasan was talking about, that would go into the NHSN submission portal to be able to measure antibiotic use. The difference here is that it's counting any amount of doses on a single day as 1 day of therapy. So piperacillin tazobactam, whether you get 1 dose or 4 doses, it counts that as 1 day of therapy. This is useful, a little bit more accurate and realistic. It does lead to being always having an extra day of therapy. If you're treating something for 7 days, and the drug has multiple administrations per day, like piperacillin tazobactam, it really becomes 8 days of therapy, counting the beginning and the end. And so that's where sometimes the guidelines, like the European guidelines, mentioned 8 days of therapy for pneumonia. It's just a different way of counting. But this is the preferred method for reporting to NHSN, and electronic systems now are becoming more sophisticated, so you'll see this more often. They do need to be standardized to be useful. So per 1,000 patient days is the most common denominator for this. And I'll show you some examples later of data that we've submitted and used for our stewardship metrics. Dr. Srinivasan talked about the NHSN AUR option, the antimicrobial utilization and resistance option within NHSN. This isn't currently required. I'm sure that he would like it to become that way so far, or someday, but so far, if you've dealt with it, it's a pretty time-consuming process to get it up and running. The vendors that provide electronic submission clinical decision support software like Theradoc and Epic has a module now that once you get it built, it's fairly streamlined, but that's the rate limiting step. And the CDC has been trying to incentivize hospitals to start submitting, and that's how their numbers are going up. But this really helps identify patterns of antibiotic use and to some extent resistance, although that portion is a little bit underdeveloped right now. Having that SAAR that he was talking about, the standardized antimicrobial administration ratio, has really helped compare hospitals to know whether or not you are overprescribing or perhaps you're doing pretty well. And then being able to benchmark different unit types, ICUs and wards, adults and pediatrics now. So he went over a lot of this, but I'll go into a little more detail on the categories because I'll show you some of our graphs. And it used to be only 5 different categories of drugs. There was the broad spectrum drugs for hospital onset infection, essentially the anti-pseudomonal beta-lactams and aminoglycosides. And with the 2017 baseline, they recalibrated and added some categories. That one and the community onset, community acquired drugs didn't change much. That's ceftriaxone, the fluoroquinolones. The MRSA agents are essentially the same, and they renamed the surgical site infection prophylaxis category to a narrow spectrum beta-lactam agent, because operating rooms weren't actually included in this, and they still aren't. So the intent of that was to have data to show that you were using longer courses of surgical prophylaxis outside the operating room. And now there's been some improvement with that, and guidelines really recommending limiting surgical prophylaxis to just a single dose for almost all indications. That can still be a problem, but this is another category to be able to track that. Cefazolin plus things like ampicillin or nafcillin or oxacillin are now in this category. There's an overall category that is every antibiotic that's reported, but now there's also the one for extensively drug-resistant bacteria with things like tigecycline, ceftolozane, or ceftaz-avibactam. And the category that's probably the most useful is the one that's for drugs that cause Clostridium difficile infection most commonly. It's somewhat controversial about which drugs to lump into this category, but they went with the ones that are in the IDSA guidelines that have been mentioned: the third and fourth generation cephalosporins, fluoroquinolones, and clindamycin for that. So we'll argue that meropenem and the carbapenems are also high risk, but there's just more studies and more data for these to make it a little more clean cut for them to say this is what we're counting. And then finally, an antifungal category that was new for invasive candidiasis, the fluconazole and the echinocandins like micafungin are in that. There's also pediatric groups, pretty similar. Like he said, azithromycin is its own separate category. And then there's a new NICU category coming soon that has its own categories. And the risk adjustments also improved. He talked about trying to standardize or really compare like-to-like hospitals. In 2014, when they had less than 100 hospitals submitting, it was really hard to break it down to very many specifics. But they are stratified by number of beds, number of ICU beds, teaching status. So this can give you some nice comparisons for the units that they have enough data for. So those are primarily the medical, surgical wards and ICUs. That's what they had before, and now they added step downs in oncology. And pediatrics is still mostly those basic units. So this is an example of a report I put in for our data that was up to October of last year when they switched over to the 2017 baseline. So it doesn't come out as cleanly and nice looking as this. It comes out in an Excel spreadsheet that's kind of a mess of numbers. So we've had analysts that can help us with Excel and make graphs. So we get a predicted versus observed ratio. So blue is the observed, how many antibiotics we actually used. We have about 500 beds at our hospital that are full, and times 30 days, so that's 15,000 patient days each month. And then the days present are a little bit higher because they count the ICU stay and the hospital ward stay as separate on the day that they transfer. So we have about 17,000 days present. So it's a little bit different than how we were measuring it with patient days, but we can get fairly similar numbers. So over that month, we had about 5,000 days of antibiotics. Now, if somebody was getting ceftriaxone and azithromycin for 5 days, that would count towards 10 days of therapy because it would be counting both drugs. So there are some differences based on how you practice your hospital, how many times things will be counted, but for the most part, it's going to wash out in the end. So based on our hospital characteristics, the CDC said they would expect us to use about 6,000 days of therapy. So the blue lines in these cases are all lower than the gray lines, and that's a good thing from an antibiotic standpoint, or we think so at least, that we're using less antibiotics than what could be expected. The orange line is what we put in for antibiotic use per 1,000 days present. So that's the scale on the right. So we have about 500 antibiotic days per 1,000 days present, using this older 2014 analysis. And then we would look at the SAAR, which is just dividing that, approximately 5,000 divided by 6,000. So our SAAR ratio was around 85 or 85% of expected. So the red line is 1, and we've been able to stay below that. So we can show our administration that we're doing a good job with stewardship, keeping antibiotic use down. But then you can further break it down into what areas of the hospital you're using more antibiotics in or less, to find out where we could improve. So on this graph that we made, anything that was above 1 is going to show up, and that would be where we might want to have our efforts in stewardship. So with this, the highest value is in the category of drugs for community-acquired infection, like ceftriaxone and levofloxacin, and it's in the ICU. So it's kind of ironic that they're not using more of the anti-pseudomonal beta-lactams and the broad spectrum. And we think that's because they do a pretty good job of de-escalating from cefepime to ceftriaxone, or piperacillin and tazobactam to amsulbactam, but maybe they're continuing longer than what would be expected, or not discontinuing altogether in patients that might not have infection. So then our goals can align with that. Knowing that information, we can say, let's go to the ICUs this year, find out why they're using antibiotics, and develop a relationship with them to do what's called handshake stewardship, where we're up on the floors more in that unit. We're not able to go to every single unit and develop those personal relationships. Our model is to have the pharmacists on the floor talk to the physicians whenever possible, because they know the patient population and the physicians in that group. So you can scale that to however your hospital works, but this has been useful information for us. And the 2017 baseline gave us more floors, more units that are now comparable nationwide. So I put an arrow here by October to show that by including more units, we also increased our number of antibiotic use days, as well as the days present, by about 1,000 in each group. And the SAAR actually went down as more hospitals were added into this model. So we thought maybe we would be closer to 1 as more people caught up to us and started submitting data, but I think there was so many hospitals submitting that it really made us look just as good, and it didn't hurt us at all. Some limitations of that, there aren't a lot of specialty units, so our oncology step down or bone marrow transplant units, ICUs are not included. Cardiac wards, you guys might have some of those, or neurology locations. So it has to be classified a certain way for NHSN, and that has to do with the hospital-acquired infections that are being submitted, the number of catheter-related bacteremias. They do it somewhat similarly with the SAAR, the standardized infection ratio, observed versus expected. Now, with long-term care facilities, we don't have that level of data on a national basis, but we're starting to gain more benchmarks, at least in the literature, of what would be expected or what could be your goal. And this is a study that we've done ongoing with Dr. Ashroff and the ASAP group, enrolling nursing homes from a pharmacy that can supply us with antibiotic use data after the facilities agree to that. And we realized that it's really not comparing apples to apples to bundle all long-term care facilities together. So we started to separate them out into facilities that took a high percentage of patients from post-acute, long-term, or post-acute short-term stays for rehab. And those patients tend to come in on antibiotics more often than a resident that's living there year-round. So when we're counting starts now, we can classify them as either low, medium, or high as far as the percentage of patients that have those short-term stays. And you can see there's definitely a difference between those. The days of therapy, though, didn't vary much between the low and the medium group. It wasn't until over 20% of your patient days are from those short-term post-acute stays that we saw a real rise in the days of therapy for antibiotic use in long-term care facilities. So we were able to graph that, and you can really see the red are those high proportion facilities, and a lot of those fall into the top third of antibiotic starts. And then the green bars are the facilities that have a very low proportion of days as those short-term stays. So about less than 5% to be a green bar. And then the yellow were mainly in the middle. And the bottom graph is days of therapy, so kind of a similar phenomenon. Now, once you know the quantity, though, you also would like to know the quality of prescribing. Are those appropriate or are those not as part of a stewardship program? So we encourage facilities to assess each antibiotic using either the McGear criteria and prospectively when it's being prescribed, or the Loeb criteria as a retrospective review. And we work with pharmacies to be able to help assess that. And another way to measure appropriateness is to look at the cultures that are coming back. If patients are being put on ciprofloxacin routinely for those symptoms of urinary tract infection, but your antibiogram susceptibilities are only 50% susceptible and 50% resistant, that's a problem that prescribing is being done empirically without actually knowing that that facility has a high resistance rate. And when you start to look at that, a lot of those patients got better even though they had resistant isolates, which means they probably didn't need to be treated in the first place, which is why we encourage that active monitoring protocol, that hydrating the patient is usually the best treatment. For those of you that work as part of a health system that has an ambulatory care clinic, the Joint Commission has been working on regulatory standards for that. And we are a part of the hospital system has Joint Commission accreditation as part of their clinics. So we've been starting to work on this for the last few years. And the main measure that's probably easiest to work on is antibiotic prescribing for acute bronchitis. Dr. Rupp touched on this, that most of these are viral. And this is similar to the HEDIS measures that insurance companies have been monitoring and the MIPS criteria that Medicare uses as part of their quality payment system. So we had 15 different clinics that we monitored over the last winter in 2018, January through April. And we compared that amongst themselves and the previous year. They had 3 different categories. The first was simply an email to all the ambulatory care medical providers, or the directors, saying that we had these tools available that were promoting appropriate use of antibiotics in patients with respiratory infections, and informing them or reminding them that many of those were viral. The active groups, though, we brought posters for their workroom, for their exam room, brochures for them to talk to patients about that diagnosis, so that physicians didn't feel like they were just telling the patient, no, you don't get an antibiotic, but helping them to explain why their infection wasn't going to benefit from an antibiotic and why it may actually cause harm instead. So that was the middle group, and they did really well. Although you could say that's attributed to the very high rate to begin with. This title should be antibiotic use for bronchitis, so high means high prescribing. When the insurance companies and Medicare do it, the metric is avoidance of antibiotic for bronchitis, because they want a high value to be positive. So 100% avoidance would be a good thing. So I reversed that in this slide. So high is bad, low is good, and they dropped quite a bit, but they had a lot of room for improvement. So that made it easy to show a statistical difference. The third group received those posters along with patient information, empowerment information at the front desk, and pledge cards asking them to be antibiotics aware using the CDC campaign that is an offshoot of the Get Smart About Antibiotics campaign materials. We didn't see quite as much improvement, although they weren't quite as high to begin with. And there are actually some studies that say introducing the concept about antibiotic use to patients early in the visit may lead to expectations that the patient should be getting an antibiotic. So then when they don't get it, they pressure the provider and ask them about it, or the prescriber perceives the perception that, oh, they're asking about an antibiotic, they must want one. I want those good reviews on Yelp, so I'm just going to give in because maybe it's a gray area. We don't know if that's what happened, but there are other studies that have shown that. So you have to be very careful. I think patient engagement is important, but how you do it maybe takes a little bit more thoughtful consideration than we expected or anticipated going into this. So this has been a success so far, and it does take some effort, but as far as stewardship goes, the cost and the effort wasn't too bad. So now on to the active learning, and just talking about what metrics do you have available, and what kind of goals do you want to take back to your facilities. So discuss among yourselves what you have available and how well it reflects your overall stewardship goals. So really what influences what we measure, a lot of times it's just expert opinion. Whatever your local preferences are and what your stewardship goals are, largely, it should be driving what you're measuring each year. We talked about ease of measurement as well, and regulatory requirements and financial pressures. Usually those kind of metrics rise to the top really fast, right? So one of those examples is C. diff testing and positive cultures or tests. So one of the interventions we did was similar to other speakers. We've said you have to have stool that forms to the cup so that we're not testing people that don't really have watery diarrhea. Well, that will work to some extent, and we've also put in some hard stops in our C. diff ordering. So this is an example of the screenshot I took of patient on Docusate. You could fill in other laxatives there. So it's one thing to tell prescribers that they shouldn't do it, which has been in our guidelines for years, but it's another when you actually stop them from ordering it. And you can see a lot more results when they have to call the lab if they want to override that. But really, a lot of them didn't even know the patient was on a stool softener or laxative. We have been talking to our nurses a little bit too, but this is another untapped area, like Dr. Srinivasan said, that we didn't really think of, or most stewardship programs are a pharmacist, a physician, an infection control nurse, but not a lot of frontline nursing support, or I guess that voice. So once you start talking to them more, you find out, okay, the patient did have laxatives, and they will tell you it doesn't smell like C. diff. That's a good reason not to test. But if you just see documentation or hear they had diarrhea or 4 bowel movements, it's a lot easier to hit that button to test. You're going to pick up a lot more insignificant colonization for C. diff. So we saw a nice decrease when we implemented this in the fall of our C. diff testing on the right-hand side of this graph. And we saw a corresponding decrease in our C. diff rates. So this is one way we've been able to lower our C. diff rates by stopping inappropriate testing. The next step we are implementing is when anybody orders an antibiotic, we have sent in a proposal at least that they find out that this is a high or moderate risk antibiotic. And it's really more of a passive informational alert right now. But if we want to, we can later then turn on some type of antibiotic timeout process, or we've been doing stewardship review of those patients on cefepime and piperacillin tazobactam. At day 2 and 3, they'll start to show up on a list so that we can intervene. And this way, the physicians can't say they've never been told that that's a high-risk antibiotic, that it comes up on that sidebar. It also says what other C. diff risk factors that patient has, so that they know the patient's over 65, they've been in the hospital, and they may have received antibiotics prior to admission. So with electronic medical records, now we're collecting that type of data, and we can push it out to the providers to have more of that clinical decision support, so that they know the patient has 4 risk factors. PPIs came up earlier as a potential risk factor. And what we've said is that when a patient is on a PPI and gets an antibiotic, that will enhance their risk over the antibiotic alone. And that helps with the controversy or the studies where PPIs, H2 antagonists on their own, probably not a real strong risk factor for C. diff, but what they do is enhance the risk of the antibiotic, make it worse. So when looking at metrics, think about the type of interventions you're doing. If you want to study the front end, interventions like restrictions or the order sets, you're going to be on this side of the diagram. These are active interventions before the prescription. If you're doing audit and feedback, you're on the back end after the prescription. Think about what you can measure at that point. So the de-escalation rate, for example. Other things you can do, like providing guidance or educational programs, those are more passive, but they're on the front end of the prescription before the choice is made. If you're using rapid diagnostics or the clinical decision support for stewardship, like bug-drug mismatches, finding out how often your interventions make a difference, and tracking that. So I think we've kind of done enough discussion, but a question to think about is, if you have formulary restrictions, how would you monitor the success or failure of that? It really depends on what you have restricted, or what I now use the term protected antimicrobial, as stewardship is about protecting resources for future generations. So we don't have restrictions, we have formulary guidelines and protected antimicrobials now. And most of the time these are newer agents. They're more expensive, so they do save money, but the resistance development is really the key message, that we want to save those antibiotics for more resistant infections, not use them routinely, because inevitably resistance develops with higher use. Now, some agents like polymyxin B or even aminoglycosides are going to have a safety concern with them. But there's also a whole bunch of other strategies. So, looking at IV to PO programs, the dose optimization, like extended infusions, or once daily aminoglycosides, pharmacokinetic monitoring. And these are all things that can be assessed. And I think the key point here is that there is no perfect metric, but as long as you're measuring something and showing progress each year, have goals. Don't pick 20 different goals or things to work on. Have one major project, a few minor projects that you can always have ready. If you have students coming out on rotation, put them to work collecting the data. It doesn't always have to be you reviewing charts or asking for reports. So there's a template I can share and put on the notes page. I meant to have as a handout. I have a larger version of this that says, what are your goals for the year, and then thinking about what are the possible metrics. Are they related to patient outcome, like preventing readmissions, or improving mortality, clinical cure? A lot of you are going to have patient safety goals, like reducing Clostridium difficile, monitoring resistance, watching the cost of antibiotics, which brings up a good point about what do different groups in the hospital care about. And this was a nice study of about 100 physicians and pharmacists in acute care hospitals that surveyed them and said, what do you actually use and what do you think is the most important? And what happens is that whatever is most convenient or at least available is what you're going to use, but then thinking about how can you move towards that more appropriateness. But also, what does your boss want, or what does your boss's boss really care about? So thinking in the mindset of business is something I've had to adjust to, and continuing to learn as one of my own goals is, what do the CEO and the CMO care about as far as antibiotic care? Really we use antibiotic use and cost as our most common metrics. The pharmacy director understands use a little bit, but they and the administrators are going to care about cost and the budget and trying to keep those costs down. The P&T committee understands the use a little bit more, but they also want to know about appropriateness. Are these the appropriate antibiotics that are we using according to guidelines? Are we standardizing care? Reducing variation is important. And the ID physicians really care more about appropriateness and the clinical outcomes like mortality, length of stay. So you may have to think about each of these and your messaging for each group involved in a stewardship program in a hospital administration. So there's problems with all of these metrics. Cost measures, price of antibiotics changes year to year. Sometimes there's new expensive antibiotics that really have a clinical benefit, and just measuring that misses the bigger picture. When we have drugs that go generic, like daptomycin, for example, our drug costs are going down. That's making us look good because it seems like we're saving money, but we may be using the same amount of antibiotics as last year. These are hard to compare between institutions due to contracts as well. And then they should be adjusted by census too. So if you can compile your antibiotic spend and divide it by your patient days, and at least you can compare it with yourself year to year and know, how much you're spending per patient. With antibiotic use and consumption, I mentioned before, be aware of unintended consequences or squeezing the balloon as it's known. We had an initiative last year that we wanted to decrease our vancomycin use and piperacillin tazobactam combination. So we showed a huge decrease in piperacillin tazobactam by educating the team pharmacists as well as some of the physician groups about the risk of nephrotoxicity being enhanced when those two are used together. But then the natural instinct is to just use cefepime or another broad-spectrum antibiotic in its place. So we had to issue guidance on what alternatives were there for different infections that didn't involve using the broadest spectrum antibiotics. So we had about a 70% decrease in the combination therapy, and we did have a large increase in cefepime use. But overall, our vancomycin use was down 20% as well through those efforts. So we could track that over time and say that we were making a difference. If you're aggregating drugs, try to think about, like I said, the anti-pseudomonals together or MRSA drugs together so that you're not decreasing one and then increasing another too much. And there's always going to be some antibiotic use. When you're setting your targets, think about a % decrease. You're never going to get to zero, and you shouldn't be at zero antibiotic use because some is always going to be appropriate. But it's up to you to decide how much you think you can reduce it based on what you have. Problems with resistance is that other than the annual antibiogram, it's really difficult to measure, and the changes that you make in antibiotic prescribing, the influence you have, it can take a year or two to really see a difference. And sometimes you may never see a difference because there's so many conflicting factors going on. Also, the lab has breakpoints that change the susceptibility rates and what they will call susceptible changes as more information comes out. The fluoroquinolones are a good example. We're in the process of updating the lab guidelines on what is considered susceptible for a fluoroquinolone. That breakpoint is becoming more strict this year, so our susceptibilities are expected to go down. So even though we're trying to use less fluoroquinolones, we won't see an improvement in susceptibilities. And these problems are a lot of the same ones you see in clinical outcomes. There's just a lot of confounding variables that go into that. So as my kind of consensus of what should you measure, what's worth measuring, this was a nice study that was a consensus of that, and there's really three categories that I would recommend focusing on. One is the consumption of antibiotics. Wherever your facility's at, acute care, long-term care, try to measure in some way your antibiotic use, whether it's days of therapy in acute care or starts in long-term care. And if you can do days of therapy, great. If it's defined daily dose, try to get reports of all the grams of antibiotics you used and divide it by that. That's available on the World Health Organization website. So if you just Google WHO DDD, you'll get that site with a list. Then monitor resistance, use that antibiogram from year to year, with the caveat you may not always see a huge difference, but even staying stable is a success. De-escalation is something that you can have special projects on, whether it's pneumonia or UTIs perhaps, but not continuing the broadest spectrum antibiotic that was started on day 1 until the end of the hospitalization. And then the third one with outcomes, the most likely thing that you're probably going to have available to you and be able to watch and improve is your C. diff rates. That's a clinical outcome that resonates with clinicians in the hospital, the physicians, as well as administration, and has that financial backing of Medicare payments. There's a ton of great examples. I'm not going to go through all of them, but I listed some references in your slides. And then finally, you want to do something with that data that you've acquired. And the feedback is going to be different for different audiences. Share it with your stewardship team or your quality committee, and then try to talk to frontline clinicians and give them feedback and encouragement that they are doing a good job and that you're not trying to beat them down with negative news all the time. Try to support them. And then share the administrative side with your business-oriented leaders. Even patients, we want to try to educate them in some way that resistance is important, the microbiota of the GI tract is important. Have some kind of routine communication with your staff, whether it's the pharmacy and clinicians, administration, bulletin boards, newsletters. And these are going to vary your messages by that audience. So one of the examples I have is with Aztreonam and how our susceptibility rates were not very good back in 2015, and we started educating in 2016 that if you're calling somebody allergic to penicillin, you may actually not be giving them the best chance for success by giving them an alternative agent. And we educated the hospitalists, the ICU group, family medicine, that we want to have better allergy assessments and not use Aztreonam as much. And it helped that this was a pretty expensive antibiotic that we wanted to reduce the use of as well. But there was a clinical advantage of using the beta-lactams like Piptazo or Cefepime versus Aztreonam, as well as an economical one. So we developed an allergy assessment guide, and this is on our website that you take this if you want. And the graded challenge part took a while to build an order set. The idea was giving small amounts of cephalosporin or carbapenem even to patients that were allergic to penicillin with an anaphylactic reaction over 10 years ago was safe according to our allergists, because 10% of those patients will grow out of their allergy every year. So at 10 years, the chances of actually having anaphylaxis is negligible, and then having a reaction to a different class of beta-lactam is only about 1% to start with. So we built an order set with monitoring and doses given every 30 minutes, 1% of the dose, then 10%, and then 100% of the dose. So with this and education, we've been able to decrease our Aztreonam use by about 2/3 over the last 2 years. And this, even accounting for the substitution of Cefepime for Aztreonam, we've saved about $75,000 a year on the drug, so that we're able to then justify the cost of our time on our stewardship team. So in summary, there's really no clear benchmark for use of antibiotics. You can set the goal. It doesn't have to, it shouldn't be 0. If you submit to NHSN, you'll have the advantage of having national comparators. So hopefully we'll get there, that most of the facilities will be able to submit that in time. And then we can say that the high performers that may have best practices and the low performers may have more inappropriate prescribing, and breaking it down by units where you're high can help with improve those. So there's those different categories. Think about process measures and outcome measures, and then comparing over time, even if it's your own facility, year to year. And then find some compelling stories that demonstrate value in your efforts to improve antibiotic use, reduce resistance. This is a patient safety initiative and a goal. You know, it really meets a lot of the priorities of health systems today, but sharing our message with them, you know, sometimes takes some practice. So that concludes my presentation.